responsibility of lecturing in this class with Mr. Deal. I've been a nurse for a long time, longer than I want to know. I've seen a lot of changes over the decades. Let's just put it this way. When I started nursing, there was no such thing as universal precautions, okay? There wasn't a pair of gloves anywhere on my unit except for the doctor. So, drastic changes over all these years. But I have survived, okay? I did survive. Don't have any issues that I know of. I have many issues, but nothing from healthcare, I guess. I started I grew up in Kentucky, graduated college in Kentucky, started my nursing career in San Francisco, and have since moved around the country many times. My husband has made me a corporate gypsy that I go follow him wherever he is, but the thing is, nursing always affords you opportunities because as a nurse, you're never going to be unemployed. You're always going to have plenty of opportunities. As a part of being a corporate gypsy, I have worked in a lot of different areas in nursing, and which is good because I get bored really quickly. And it's a pretty good thing not to worry about being bored because you can always change and be completely different. I started out in cardiology, thought that's where that I would spend my whole life. I actually worked with Dr. Thomas Fogarty. He is the doctor who invented the cardiac catheter, balloon catheter. Very smart man, but very, very smart man, because he invented the balloon catheter at the age of 18 when he was a scrub tech in the OR. Before he ever even went to college, it took him years to get anyone who would try to make it for him. But, yeah, full history. But I have moved around. I have done about every area of nursing that you possibly do. My passion is community health. I love home health and hospice, and I was a school nurse for 14 years of that time as well. So, been around the block a few times, saw a few changes, and I want to encourage you that you will be fine. I know some people right now are overwhelmed about this time of year, and you're going to be fine. I just want to encourage you, just keep chipping away at it, just keep on keeping on, and you're going to be fine, okay? So let's talk about comfort. Anybody in here is probably not very comfortable right now because you're stressed, you're overwhelmed, you got lots of stuff going, and you have 1,000 things you need to do and no time to do it, right? That is where we're going to start in reality, because as a community nurse, I'm always been well-rounded in reality. You have ideal, you have all the sparkle, but then you got to get some ground in reality. So I have done home health in my personality, where I've had to backpack up to a house. I've been in homes that had dirt floors, no electricity. It's been an interesting ride. So reality is where I live, and I will hopefully move you along in reality as well. Okay. So we're going to talk about comfort. Comfort is a broad spectrum. It can be, it's a continuum. You're more comfortable 1 minute than you are the next minute, or one day to the next day. But it's a spectrum of being a physical ease or impaired comfort, whatever that may take on, and what that may look like. Can everybody hear me okay? I don't have anything to snap the mic to, so I don't really want to hold it, but if you can't hear me, let me know, okay? Pain is whatever the experiencing person says it is, and it exists whenever they say it doesn't. Yes?
There's supposed to be a slider.
Oh, what happened? So our objectives are listed there. And this is our concept map for comfort. It's a state of physical ease, as I said. You can have impaired comfort, which can be acute, it can be chronic. The patient's report is the most reliable. Lots of things impact our comfort, our pain experience. What makes you comfortable and happy might not make the next person beside you comfortable and happy, right? It's very individualized, very unique to the person. When you're assessing pain, you want to make sure that you ask the person, what's their comfort level? If they can express themselves, that's very helpful. But there's lots of patients that you're going to be caring for who can't express themselves, either due to cognitive impairment, or they may be on a ventilator, they may be anesthetized, lots of reasons that they can't communicate to you that they're having discomfort. So you have to be astute at watching behavioral cues, but if they can talk and they can articulate and express themselves, you're going to ask them what their comfort level is, give them a way to assess on a scale to 1 to 10. We're going to talk about some different scales. But make sure that you are inquiring of them. You're not judgmental. You're not going to say, you're going to believe what they say. That's how we operate. So a state of ease. Pain has, you can be completely comfortable and at ease, or you can be in excruciating pain. Wide variety there. So pain has different categories. It can be acute, it can be chronic. Acute pain is temporary usually. It usually resolves whenever the healing process or whatever the pathological cause for it is taken away. It can be caused by trauma or injury. Chronic pain, and it's also, acute pain is protective. That's what is the hallmarker on acute pain. It is your body telling you, oh, warning, warning, something's going on here. You put your hand on a hot stove, the pain tells you about it, and what do? Get your hand back, right? Whereas someone who's cognitively impaired might put their hand on a hot stove and do what? If they have altered sensory perception, they don't feel that. The same thing with a diabetic who has neuropathy issues. They can walk around with a tack in their shoe or a pebble in their shoe and never know it, and never know that they are developing a ulcer or a sore open area. That is how my brother lost his leg as a diabetic. He had a pebble in his shoe, did not know it, and it was on the bottom of his second toe that started making an open area, and he ended up losing his leg as a result of it because he was not aware. And once that open area starts, it just grows and grows and grows. So acute pain is a good thing. We want to know. We don't want to just kill the pain. We want to know, why is it there? Investigate the reason for it. Chronic pain, it's not protective. It's lasts more than 3 months. No real cause. Maybe untreated acute pain, but there's no real cause for it. There's different types. There's somatic, which is more superficial in your limbs. There's visceral, which comes from the body cavity. The nociceptive pain is damage to skin, tissue, and then you have neuropathy, I'll get it out. And like diabetic neuropathy, it's a shooting, burning, pins and needles kind of thing. Adjuvant medications work better for this kind of pain instead of the analgesics. And then we have the problem with pain and substance abuse disorders. We, as a profession, sometimes can be judgmental in how we interact with people. And so we need to be very aware of our own personal biases, because even if a person has a substance abuse disorder, they can still be in pain. And they have the right for that pain to be managed just like any other patient, just like a cancer patient. So they have the right for that pain to be managed. But many times, because of our biases and our judgment, their pain is undertreated because they're not believed, or people are afraid of helping their addiction, so they don't give them strong enough medication to take care of their pain needs. So pain is one of the most common reason that people even seek medical attention. Why they even take medication, and it's also a major cause of disability. So although normal pain serves as a protective mechanism, we always want to know. We always want to investigate that pain. So we're going to ask our patient about its location. When did it start? Is it localized? Is it widespread? What's the intensity? Is it moderate to severe on a scale of 0 to 10? Frequency. Does it come every few minutes? Is it coming every hour? Do you have it every day? Is it constant? Does it come and go? Duration, is it acute? Just started now, or you've been having it for months? Older people are at risk for chronic pain. But pain is not a part of the normal aging process. It shouldn't be something that older people accept as, oh, I'm just growing on, I have to just live with this pain. No, pain can be managed at any age, and it should not be a part of, considered normal for aging process. But because of their body systems, because of their polypharmacy, their organ systems are not working quite as well as they used to, they are more vulnerable, and they also have less pain tolerance.